Hi everyone. I'm Ben, one of the former surgical teaching fellows, now doing major trauma. I've been working on the Hospital at Night project with Kaveetha for the past few months, and we've taken over from Jocelyn, who carried out the Hospital at Night simulation prior to COVID. So the core concept essentially is that this is a simulated on-call experience for the CP3 medical students when they come through their surgical block. It's a chance for them to prepare for an on-call scenario and deal with the challenges and anxieties that come with facing your first on-call. With COVID, things have changed substantially, as has everyone's projects, in that prior to the restrictions, we used to bring in a number of actors and simulated patients for the students to take histories and examine, but due to the risk of transmission, that unfortunately all had to stop. And so we tried to take things in a slightly different direction. I think Menti is a favourite of everyone, and that's what we've used essentially to collect a lot of our data. Just whizzing quickly through this, we just asked our students, so we had 90 students come through between October and February, October 20 and February 21, over 18 sessions, and we got a wide variety of responses about what an F1 does and what our students have in terms of anxieties. And I think it can be boiled down to a fear of the unknown, essentially, not having support, not knowing what an on-call shift looks like. The general structure of the simulation is seen there. So we have 3 students who are working in separate routes with 2 separate Hospital at Night coordinators who would essentially act as switchboard, senior support, advice over the phone, etc. The circuits that we would run, so we would begin with a small introduction and have a circuit that lasts approximately 40 minutes. During this, they would have a number of tasks that would be handed over to them. We'd split them into kind of minor and major sorts of patients to be reviewed, and they would have to contend with interruptions that would come every 10 minutes. At the end of every circuit, there would be a handover and debrief, and learning from when I ran this as an FY1, I noted that students wanted to do this again so that they could improve upon their past their previous attempts, and so we decided to run a second circuit with different scenarios so that students could immediately put into practice what they had learned in their debrief. The circuits that we set up were all set up in the UMEC A-floor rooms, and essentially what we used were very, very low fidelity patient notes. Essentially, the students would be placed into different teams, so red, green, and purple, and we would call to the phones that would be set up in the rooms to call for each of them. So this is the meat of the session. So this is one of our major scenarios, essentially building upon some of the max teaching that we did on NG2 placement and never events, essentially. Primarily what we were trying to do was improve non-technical skills in communication, task prioritization, and clinical reasoning with these paper notes, essentially, that would give the students a large amount of data to process in a short space of time, causing them to kind of come up with a management plan and escalate appropriately, speak to seniors, and communicate when they needed help, and so on. And that's just some of the information that we'd provide. Sometimes it would be an image, such as this chest X-ray. Sometimes it would be an ECG, blood gas, blood results, etc. And they would have to collate all this information together and come up to a balanced diagnosis and management plan. So we used Likert scales in order to collect our information. So in the task prioritization domain, clinical reasoning domain, and communication domains. Essentially, after every circuit that was run, we would have this prior to starting the exercise, after the first circuit, and again after the second circuit, with debriefs each time going through each of these domains and trying to learn from different segments. So just very briefly on results. So between sessions 1 and 3, we found that the students were on average increasing in their confidence, their self-reported confidence in task prioritization and clinical reasoning by approximately 35% in each domain, and the same again in how they rated their communication skills. So at the end of the session, we again used some Likert scales to just get an idea of student satisfaction. So we noted that although the students found the simulation stressful, they did enjoy, and they found the session particularly useful, and commented that the debrief sessions helped them improve their learning process. So in terms of what they learnt or what they've reported to learn, improvement in management and structure and handover are things that they were concerned about, which we seem to have hit in the free text. Again, what they found more useful, so going through the management plans, the handover process, and just practicing speaking on the phone and speaking to seniors over the phone, which I don't think they have much chance to do as students. Promisingly, what should we change? Most common response was nothing, which was quite flattering. But in terms of the timing of the sessions, I think everyone reported that by the time they'd started, it felt like they were finishing the circuit. But the entire session did run from about 1 o'clock till 4 o'clock, so it was a full Friday afternoon to run. This is just a discussion about the fact that we used essentially very crude methods to simulate complex clinical scenarios and to challenge the students to develop skills in clinical reasoning, communication and prioritization, which was, forced upon us by the restrictions and the lack of actors and simulated patients that we would normally bring in for these sessions.